Okay, welcome back, everyone. Gordon and I want to thank everyone for your resilience in getting through the whole day. This is our the last final stretch of the meeting. We are very excited to have this next presentation, which will be given by Dr. Brennan Spiegel. It'll go from 3:35 to 3:45. I'm sorry, 3:35 to 4:05, and then we will start with our final session of diversity, equity, and inclusion right after that. So we're possibly going to be about 5 minutes over for the day. So we appreciate your patience. But I'd like to introduce Dr. Spiegel. He's Director of Health Services Research at Cedars-Sinai Health System. He's the Assistant Dean of Clinical and Translational Science at the David Geffen School of Medicine at UCLA, and he directs Cedars-Sinai Master's Degree Program of Health Delivery Science. He directs the multidisciplinary team that investigates how digital health technologies, including wearable biosensors, smartphone applications, virtual reality, and social media can improve people's lives. So we talked earlier about just the 25-year celebration. I can't think of a better person to help kind of finish up the later part of the day talking about virtual interventions for pain. He's also very active in a number of different areas. He has a book, VRX, How Immersive Therapeutics Will Transform Medicine, which was published, and he receives funding from NIH, PCORI, Robert Wood Johnson Foundation, IRS Foundation, Veterans Administration. I'm not sure when Dr. Spiegel sleeps. And to throw this in there, which he'll have to explain to us, he's also very active in the gerontology space, where he serves as editor-in-chief of the American Journal of Gastroenterology. So we'll turn it over to Dr. Spiegel, and thanks again for presenting on the science and practice of VR analgesia.
Okay, well, thank you very much for the kind introduction. And I hope that this talk will keep you all awake and alert as we kind of finish up the curriculum for the day. So I'm going to start with this picture, which is a picture of me with one of our patients here at Cedars-Sinai Medical Center here in Los Angeles. She's allowed us to show her image. And she's one of now over 3,000 patients here at Cedars-Sinai in whom we've used virtual reality for a variety of different conditions, but most notably for pain management. And today I'm going to talk about what happens when we use virtual reality and why would we use virtual reality and how does it work? And so this is now the beginning of a new field of medicine that the FDA calls medical extended reality, or MXR. That's the new term. And I'll introduce this idea of medical extended reality today. So to get us started, I'm just going to show a few pictures because this is very much a visual science. And this is a picture I took a few years ago with one of our older headsets of a young man with sickle cell anemia who's in the midst of a pain crisis. Just moments before we took this picture, he was doubled over in pain in his long bones and in his chest. But at this moment, he is flying in a helicopter over fjords in Iceland. And you can see the emotional experience that he has on his face. And I'll show you a video a little bit later of what actually happened when he used virtual reality and how he experienced it. And then I'll talk a little bit about what's happening potentially in his brain. I didn't have a functional MRI scan for this particular patient, but we do have fMRIs for other patients. Here's another patient of mine who has advanced liver disease. You just heard earlier, I'm a gastroenterologist by training. And so this patient has cirrhosis, and we really could not use opioids because it would trigger hepatic encephalopathy and worsen her brain fog. So we were trying to look for other ways to help manage her pain. And again, I'll show you a video shortly of her using virtual reality and talk about why we use it, what they're looking at, and how it can be helpful, not just for pain, but for a variety of other conditions. But today I'll be focusing my comments on pain in particular. So most people, when they think of virtual reality, they think of a gaming platform for, gaming and entertainment. They think about teenagers playing first-person shooter games, maybe in their parents' basement or something like that. And for sure, VR is all that. But it turns out long before VR was available to the masses for gaming, there were psychology departments all around the world and elite universities studying these headsets and how they can impact the human mind. And in fact, it really began through the Department of Defense as a technique to help simulate complex environments like flight simulation for pilots. But only recently have these headsets become good enough and cheap enough that we can use them as part of everyday clinical practice. And here at Cedars-Sinai, we now have a virtual reality consult service. We call these the virtualists. And I'll talk about what we do and how we use it. Now, to kind of orient you to what VR is capable of, I want to start with a story here of one of the first times that I used virtual reality. It was at the University of Barcelona. And it turns out this is a center of excellence for virtual reality research science. And there's a professor out there named Mel Slater, who has been studying virtual reality for years and trying to understand its impact on the human mind. And I want to tell you a brief story and show you what happened when I visited his laboratory. And so when I went there, one of the rooms in his unusual lab looks like this. And it's sort of a dank room with dark walls, and there's a chair and a table. And he had me sit down in that chair, and he had me kick my feet out onto the table in front of the chair. And this is one of his postdocs, Ramon Olivas, who is setting me up for this virtual reality experience. And in doing this, he put these motors on my ankles and on my wrists, and I'll explain why in a moment. And then he put a headset over my eyes. And all of a sudden, this room turned into kind of a beautiful looking living space. And there's one screen on each eye, so it's stereoscopic. But what my brain experienced is a three-dimensional environment, a single image that it was three-dimensional. And as I looked around, I found myself as if I was in this room. And anyone who's used virtual reality knows what that feels like. It's a sense of presence, as if you're actually there. So all of a sudden, this room looked like this. And then what they asked me to do is to start moving my legs on the table. And they drew these blue lines out, and they asked me to trace out those blue lines with my feet. And sure enough, in perfect one-to-one synchrony, as I moved my legs, I saw those virtual legs move at the same time. And I started to wonder, whose legs are those? They move like my legs. And they look like my legs, but I'm in a computer simulation and there's a computer somewhere in this room running thousands of lines of code, convincing my brain that I have now embodied this digital avatar that I was now within. Now, what happened next is he dropped these balls from the ceiling. And as each ball struck my body, I could physically feel it because the vibration motors that they had put on my ankles and my wrists were firing at exactly the same moment that these balls hit my body. Now, at this point, I had what Professor Slater calls full body ownership. I believed, as deeply as I can believe anything, that I was that person. And once you do this, once you hit this state, you can do all sorts of very interesting things in virtual reality. What I want to show you next is what he did to me. And it's hard to put into words, and it's hard to imagine what it actually feels like. So all I can show you is the video of it. What happened next is he separated me from me. He separated my body, and I started to disappear up and float into the ceiling. And as I did so, these balls followed me, and they kept striking my body, reinforcing that I was still a living entity. But I looked down and saw that body that I had just occupied, and it was motionless, and it was vacant. I'm going to show it to you again because it's just so bizarre to contemplate that I was having a complete out-of-body experience. My brain believed that I had just separated from my body. And in fact, I recognized at that moment that I had died. And I looked down and I thought, this is what it's like to pass away. And it's not a catastrophic process. In a way, it was a spiritual process, almost a mystical experience. And in fact, as I tell this story today, 4 years later, I can still remember vividly what it was like to go through this. And I've even thought a little bit differently about death ever since having died in virtual reality. And it turns out I'm not alone. It turns out Professor Slater has published this study entitled "A Virtual Out-of-Body Experience Reduces Fear of Death." And in a randomized controlled trial, very elegant design, he found that when people are randomized to this out-of-body experience versus a version where you don't leave the body or you can still control the body remotely, that people's views of death changed. Very profound. And what this early sort of story here tells us is that VR is not just a tool for gaming and entertainment. It's a tool that, if we use it correctly, can profoundly modify perception. Perception of the world around us and perception of the world within us. And if we use it then to recalibrate unhealthy perceptions, VR has this potential to become a radical new therapy to potentially improve health-related quality of life. And this is what we've been focusing on in our lab here at Cedars-Sinai, funded by NIH research, and using in our own clinical practice. And I'm going to tell some stories and show you some more data. So I want to show you this scene now. This is a scene of dolphins swimming in a 360-degree environment. And this is something we often use in the inpatient environment, where we use a virtual reality headset and have people disappear into this beautiful world, and you can hear this music. And I had a patient recently who had severe abdominal pain. And the pain, it was unclear what its origins were. CT scan was normal, upper endoscopy normal, colonoscopy, every lab test you can imagine, all normal. And so they called my team in as a gastroenterologist, and I've decided to use this scene. And she looked around in this scene, and after about 4 minutes of quiet, she started to cry, which is very common in virtual reality. I said, "Are you okay?" And she said, "I am." She said, "I think I know why I have this pain." And I said, "Really? Tell me more." She said, "Yeah, it's because of my brother." And I said, "Your brother, right? What do you mean?" And she said, "My brother died of stomach cancer, and that's how I'm going to die too." I said, "But we've been in your stomach, right? We looked with a camera. You don't have stomach cancer." She said, "I know that. You guys keep telling me that, but I'm unwilling to accept it because I'll die eventually of stomach cancer, even if it's not there now. But you know what? These dolphins," she said, "are telling me I need to move on with my life. And by the way, my pain is better and I want to go home." So a dramatic story. And I thought, man, I'm a gastroenterologist, not a psychiatrist. But what was happening in her brain at that moment? And how robust is that benefit anyway? And how often does that happen? And I didn't have a functional MRI scanner, but if I did, we do have a little bit of information now about what happens inside the brain of somebody during virtual reality, particularly as it pertains to pain. Either visceral pain of the sort I just described or somatic pain, like this example from the University of Washington. This is Hunter Hoffman at UW, who has been studying this for years. And in this experiment, famous experiment, which is now 14 years old, he used a thermal probe and placed it on the foot of research participants. And then he did functional MRI scans, and first without virtual reality, and then with a calming virtual reality environment. And what he showed repeatedly was that there was a reduction in the pain signaling. And if you look carefully, the signaling is reduced not just in the sensory cortex here, where you have the physical experience of pain, but also in the emotional centers, in the limbic system, in the insular cortex. There's a drop-off in the signals of pain. And he showed this repeatedly. And now this has been reproduced clinically. So what you're looking at here are two famous examples of virtual reality studies for pain. On the left, also from the University of Washington, famous study of people with severe burn injuries going through bandage dressing changes. And on the right, women at the University of Michigan going through labor and delivery. And in both cases, they were randomized to VR versus no VR. And what you'll see here is in both cases, they're the same outcome measures. So there's not only the sensory component of pain, the worst pain, but also affective components and cognitive components of pain, time spent thinking about the pain, the unpleasantness of the pain. And in both cases, there was a reduction afforded by virtual reality. Curiously, they also measured fun, which is a strange outcome for a clinical trial, but relevant. And in this case, found a tremendous increase in fun while people were having dressing changes, which is a strange concept. This is a study that we did to reproduce this. In this case, we were looking at laboring women at Cedars-Sinai using a biofeedback version of virtual reality, where as the participants breathed in and breathed out, the microphone in the headset could detect their breathing, and it drove a metaphorical narrative where they were birthing sort of a new life within this virtual world in the form of a tree, that they breathed life into the tree as they were actually going through labor and delivery. Now, this is more data from Hunter Hoffman's work at the University of Washington, where, again, he's looking at a combination of virtual reality, yes or no, plus or minus intravenous opioids. And there's a lot of data to take in here all at once. But what he was able to find is there is an incremental benefit of VR over and above opioid Moreover, when they used VR without opioid, there were very similar results from just having the opioid, suggesting there may be an equivalence between virtual reality and opioid for, in this case, acute pain. We'll talk about chronic pain in a moment, which of course is a different form of pain. But for acute pain, we now have extensive data in the form of meta-analyses that demonstrate benefits for virtual reality in the acute pain setting. Now, having studied all of this research, we decided we needed to kind of look into this in more detail. And this is where we work, is me at Cedars-Sinai. And if you go into a hospital like Cedars-Sinai, it looks like kind of any other hospital. This is a typical room. And, you know, this is not really a place of rest or a place of healing. If people sit here all day, this is what they look at. And somebody like me shows up, and then we disappear, and then we come back again. And this is the ebb and flow of being in the hospital all the time. And so we thought there must be a way that we can do better than this. What if we were to give people virtual reality and allow them to escape the four walls of the hospital, to go to fantastical destinations outside of those four walls? For example, this patient is reaching out as a blue whale swims across her visual field in her own hospital room. And we've been talking to our patients to learn more from them about what works and what doesn't, and how does it feel, and what's the experience like. And, you know, some people really enjoy this, maybe just purely for the fun of it. They want to go somewhere, like they want to go on a vacation while they're in the hospital. Maybe they want to go to Hawaii or go on a safari or go into an ice cave or something like that. But others we're learning are benefiting not just from the distraction, but from biofeedback. And I'll show you in a little bit how we're now using biofeedback to drive these narratives and also to give people insight about the way their mind and body are connected. And I'll show you more about that. This is an example of one of the environments that we use at Cedars-Sinai. This is kind of like a cyberdelic. It's a psychedelic of sorts. I think I saw psychedelics are on the syllabus earlier. And of course, we know psychedelics work by inhibiting the default mode network of the brain to allow for this non-dual consciousness. And it seems from head-to-head studies of psilocybin versus virtual reality that the phenomenology is extremely similar. And in fact, we use these worlds for people who are vulnerable and in pain, and we'll bring in aspects of their life, for example, pictures of their family or their pets or anything they want, and integrate them within these virtual environments. And the responses are often dramatic, crying, tears, and you can imagine. And so I want to show you now two patients using virtual reality for the first time. In this case, I already introduced both of them, and you'll just see what they say as we bring them not to these cyberdelic environments, but purely just to some relaxing environments. The first one is that patient with sickle cell who's flying in a helicopter, and the second is this woman who's on a beach in Hawaii. So we'll see if it helps with the pain or not. Mm-hmm. You'll tell us.
Yes.
And we'll go from there. Okay, any questions about that?
Pull that down over your eyes now.
Should load up.
Whoa.
What do you see?
Horses?
Yep, okay. And over the bridge. Is that working?
Yes.
What's happening now?
The helicopter, waterfalls.
Mm-hmm. Have you ever been to Iceland?
No.
With the music and everything, it's real peaceful. Oh, it's people. Hey. That's cool.
So what'd you think?
It's pretty relaxing.
Uh-huh.
Especially with the music and everything, and then the different scenery. Like, it was just one part where it was like a waterfall. You're sitting in a cave,
right?
And it's a waterfall right next to you. Almost made me forget I was here. Like, cause you're there.
Right.
It's like you're really there. You're hearing the waterfall, and everything is like you look around, and it's the whole scenery.
Right.
It's like you're immersed in it.
How did it make you feel?
Relaxed. Very relaxed.
Mm-hmm.
I wasn't thinking about the pain.
You weren't?
No, I wasn't.
Really?
I was just thinking about being there
Uh-huh.
and having a good time.
Uh-huh.
Yeah.
We'll let Dr. Herman know.
Okay, thank you. Thank you.
Good, okay.
Yes, but I really did like it. I enjoyed it really much.
Excellent.
Thank you so much
You're
for
welcome.
picking me.
So I can show you studies, and I'll show you a few more, but really having seen the patients experience this kind of inspired us to study this in more detail. And so this is one of our earliest studies. This is published a couple years ago now, a randomized controlled trial looking among all comers with pain in the hospital. They just had to have pain of 3 or greater. And we randomized them between 2 different conditions. One group just watched a 2-dimensional screen on their television set of sort of a wellness and relaxation channel, whereas the other group had a library of virtual reality experiences that were similar. And when we looked at over the course of their hospital stay, looking at the pain scores that were documented by the nursing staff, we saw a greater reduction in pain in the VR group versus the TV group. But really, it became really clinically important, especially in these patients with the greatest amount of pain. Scores of 8, 9, or 10 out of 10 is where we saw the largest relative benefit of VR over the television administered form of relaxation. Now, another question that comes up is, what about outpatient use and for chronic pain, not just for acute pain? And this is a study that was published by a number of people, including Beth Darnell at Stanford, who's a senior author, a randomized controlled trial of a 56-module, 8-week CBT-based virtual reality experience called EaseVRX here, and versus a sham VR, where you wear the VR headset and you see scenes, but it's as if it's a widescreen TV on a wall. It's not an immersive experience. And this is for chronic lower back pain. And here you can see days, up to 56 days, seeing a separation in the average pain intensity in favor of the virtual reality group. So this is one of the first home-based studies of the self-administered skills-based VR program. It's not just a distraction, but it really incorporates various aspects of CBT. And I'll get into more detail about how we can do CBT through virtual reality in a moment. Now, that program I just showed you just 2 weeks ago was approved or authorized by the FDA. And this is a very important advance for the MXR field, or medical extended reality field. This was a de novo application, and interestingly, it received breakthrough designation, which has implications for Medicare reimbursement. So we're going to be learning more about that in the coming years, or coming months, really. Now, this is an example of one of our ongoing NIH trials, where we're kind of expanding upon what's been done. In this instance, we're trying to understand, is there something about VR itself, or is there more specifically? So in this case, we're using the sham for lower back pain, and we're using a variety of distraction-based experiences, beautiful, immersive, almost watercolor pastel environments with beautiful music, just to see if that alone, giving a library of distracting experiences, or is it really more about the CBT and the skills, psychoeducation, biofeedback, relaxation. And so this is a 3-arm study. And if you have patients with chronic lower back pain, we can enroll anybody, anywhere in the country. And we can do it all remotely. We don't need anyone to come to our medical center. Happy to answer questions about that. This is another similar study that is funded by NINR that we have ongoing now, which is really for home-based management of chronic pain among rural Americans. And here it's a comparative effectiveness study looking at the sort of best of breed home-based 2D digital mobile health application, the Pain Trainer app developed at Duke and Northwestern, versus the new FDA-cleared Ease product. In both cases, we're looking head-to-head to see if one is better than the other. Now, I mentioned I'm a gastroenterologist, so I just can't help but notice that virtual reality has also been used during painful procedures like colonoscopy. And this is going all the way back to 2004 in Japan, where patients using patient-controlled analgesia used less propofol, had lower pain scores and higher satisfaction when they were randomized to this rather primitive form of virtual reality. And there's a lot of data there to take in, but the main point is that there was a stair step. The visual versus the visual and audio, when you have them combined, you have a greater analgesic benefit compared to one or the other alone. Now, I mentioned inpatients. We've looked at this quite a bit, and this is a meta-analysis that we published several years ago looking at VR for inpatients. And we've also been looking at the cost effectiveness of this. And the idea is, can it help reduce length of stay, reduce opioid usage, for example, and complications related to that, improve satisfaction scores, which is tied to Medicare reimbursement? And this is a paper we published several years ago looking at a health economic analysis of establishing an inpatient virtual reality program. And this was the basis for the program that we now run at Cedars-Sinai. When we do analgesia with our patients, we always have to assess whether it's appropriate. So obviously, there are some contraindications if people can't wear the head mask, can't, facial fractures or have facial wounds or are in a halo and can't move their head. Patients who have severe panic disorder, we have to sometimes be careful. Schizophrenia is not unto itself a contraindication. In fact, there's treatment paradigms for schizophrenia I haven't even talked about today. We established the set and setting, kind of this very much the language used from psychedelic literature, trying to explain what this is about, where you're going to go, we're going to be here with you. Administer the treatment, sometimes using biofeedback, and I'll show you that in a moment, how we use biofeedback during the procedure. And then, of course, we debrief and spend some time breaking down what just happened, what did you feel, what happened inside your body, and so on. And I'll show you another example or two. So what I want to show you now is a worked out example of a program that we've been creating for a form of pain, visceral pain, abdominal pain that occurs from irritable bowel syndrome or IBS. Because I'm a GI doctor, I have a particular interest in IBS. And in my last couple minutes, I just want to show you how we build these programs. So this particular program is called IBS VR. It is an unfunded program. We built this all ourselves. Just so in terms of conflicts and so forth. And so what I'm going to show you here is the way we create these programs is we create an entire virtual clinic, and patients can experience this clinic at home. Normally we always bring patients to the clinic, but with VR, we can bring the clinic to the patients, and they can unlock this clinic bit by bit, ideally in partnership, of course, with a clinician. And that's the model that we've been using. And I'll show you how we do that in a moment. But I just want to show you a little bit about how we do this, because when people enter this clinic, this virtual clinic, they enter the lobby and they're greeted by a guide. And it turns out people don't always want humans in these worlds. We've created a guide who's a little robot who turns out to be quite knowledgeable about CBT and about IBS. And this robot helps bring the patient through the clinic. So I'll just show you first what patients experience when they enter this clinic. And I'll show you a couple of these rooms and then we'll wrap up. So here's the lobby, and here's what happens when people first put on their headset.
Hi, and welcome to IBS VR. My name's Maya, and I'm a virtual therapist. My specialty is irritable bowel syndrome, or IBS, and I'm excited to meet you. I've been programmed to help people learn about IBS and practice techniques that can improve IBS symptoms. To help you learn more about IBS, I need you to imagine that you're now a doctor. Don't worry, I'll be here as your assistant to walk you through everything step by step. Now let's see your first patient.
Now that you've met Maya, you're able to start going through this clinic. And in the exam room, we do a role reversal, just like I showed you at the beginning of this talk. When I embodied this other body and had this out-of-body experience, we put our patients in the body of the doctor in a role reversal, which is an established technique to become the doctor and sort of get out of their own mind and examine patients.
Here, take this stethoscope. I'll show you how to use it.
Sorry, the video is a little jittery on my end. Hopefully you can see it.
Now place the stethoscope over Taylor's stomach, and you'll be able to listen to what is happening in her gut. I hear a lot of rumbling sounds and some pops or clicks. We should investigate what's happening.
So this continues, and as the patient continues through this exam, they start to use holograms, they look at the bowel, they learn about what's happening, but then we introduce the brain-gut axis. And the idea that GI symptoms in many cases are related to the processing of pain in the mind. And after we introduce all of these concepts, we can start to introduce other environments. For example, the chill room is a full full IBS hypnotherapy environment. And what I want to show you here now is how we use biofeedback, because in the headset itself, we can measure pupillometry, we can measure heart rate variability, we can measure eye tracking, and also we measure something called cognitive load, which is an integrated metric of autonomic function. And what you're looking at right here is a patient who is in the chill room, decided she wanted to be on a beach, and was in a great deal of distress and pain. We just videotaped this a couple weeks ago. And what you see on the left is just before we started, and then once she got into the meditative environment, you can see in real time this drop in her cognitive load and stabilization of her heart rate variability, got more variable, pupils changed. And we were able to talk to the patients about this, and just to show it to them is so powerful that they understand the benefits. This is me doing this and somebody interrupting me every couple minutes as I'm trying to meditate peacefully. Very responsive metric that we've been learning to work with. So, there's other things we do in theater of the mind, for example. We do actual cognitive behavioral therapy. We can put people into stressful trigger environments. For example, patients with IBS don't want to be in a bathroom, a public bathroom, for example. We can literally put them in there and create the environment where they're stressed and people are waiting for them, and do all of this stuff. And what you're looking at here is this metaphorical movie theater where we start off the whole thing. And I'm going to skip this because I want to finish this up. But the bottom line for all of this is that if virtual reality is a treatment, then we need a VR pharmacy. And that's where we're moving right now. This is an infographic from the first public workshop that the FDA held back in March of 2020, just at the start of the pandemic, where they coined this field medical extended reality, or MXR. It's a very unusual branch of medicine where you have Microsoft, Facebook, and Cedars-Sinai all in the same list of participants. And so it's been an exciting and interesting time. If you're interested in this topic, we put on a conference each year. It's called Virtual Medicine. We will be going live in person if things go according to plan next March. You go to virtualmedicine.org if you want to learn more. We also have extensive resources and videos and lectures that are all available. This is the only conference I've ever seen where people actually scalp tickets to get in. I'm not even joking. So if you're interested in this, I also wrote this book that came out about a year ago, VRX, which is really about VR, but it's really about what is VR teaching us about the mind and the body and the connections between mind and body, and this intersection between psychology, philosophy of mind, neuroscience, clinical medicine, and technology. So with that, since I'm down here in Hollywood, I'm going to end with a scroll to credit all the many people that participate in this multidisciplinary research that I've presented to you today briefly. And if you're interested, I'm on Twitter. I talk about this stuff a lot, and our virtual medicine conference also tweets about this kind of stuff a lot too. Hope that was helpful and that you're still awake and alert. And thank you very much for the opportunity to be here today. Sorry, I went over a couple minutes, but I'll end there, and thank you again.
Brennan, that was superb. I mean, I was listening to it with mouth open. Yeah, I do have, my kids have the Oculus, and I've done the VR, so I know what it's like. And I have that trip. I bought that thing with it was just amazing. When do you think we have a problem? The rest of the world crashed around you. So I'm not sure how many people have watched you, but we're going to encourage them to re-look at it, because they shouldn't miss out on this.
Okay.
One question that came in before is, do they get nausea with this? Because in the shoot 'em up games, if they move too quickly, then nausea can be a problem.
Yes, so that's called cyber sickness. That's the technical term for the vertigo and attendant nausea that can occur, particularly for shoot 'em up games or games where there's rapid movement or horizons that are changing eye level. This can throw off the vestibular system if there's a mismatch between what the inner ear is detecting and what the eye is seeing. So faster processing time can help reduce the risk of nausea, but also when we create our environments, we try to keep them stable to reduce this sense of cyber sickness. But it can happen up to 5, sometimes 10% of people in our studies will have some degree of dizziness. Typically it gets better and people often want to stay in it, but for some it can really be, it could be dose limiting.
When do you think this will be ready for prime time? In other words, I can go out and buy an Oculus or a whatever it is and give it to my patients, tell them to buy it, loan it out or whatever. And do you think it's going to be very specific per person? It sounded like in some ways you were giving it to everybody in the hospital in that trial and just seeing what worked.
Yeah, so you're right. We need to find the right treatment for the right patient at the right time. And there's, so many different programs now for different use cases. I mentioned, for example, in passing, it can be used for schizophrenia, for eating disorders, for smoking cessation, labor and delivery, for hypertension. So naturally, the VR treatment is going to be different for each of those people. And I think of the VR headset like a syringe. It's not the syringe that matters, it's what medicine goes through the syringe that matters. And so the software is the equivalent of the medication, and the headset is just the syringe that delivers it. So, that's the first answer, is we're trying to get better at picking the right treatment for the right patient. On our website, we do have a list of our favorite VR programs that we don't receive any money or sponsorship from any of them. These are all software, some of which, like Trip, are available widely. Other requires a prescription. So we're going to start seeing more and more. There's over 200 hospitals using VR around the country right now. And with these FDA approvals, I think we're going to see more and more, particularly if Medicare starts to reimburse for it.
Great. Thank you very much indeed. Steve?
Okay, so we're going to move on. That was excellent. Again, thank you very much, Dr. Spiegel.
Thank you very much.
We're looking forward to our final presentation here. And thank you for giving your information that we can contact you as well, because I know there's a lot of other questions. But the final presentation, which again, we're very excited to put together when we started to kind of plan for this meeting a number of months ago. The next presentation is Building Diversity, Equity, and Inclusion, Examining Our Own Implicit Bias in Pain Management. Swedish is, I think, really fortunate to have a really strong program, and we've done so much just in the last couple of years around this area. So I wanted to introduce the four speakers, and I know that they have a lot to say in 1 hour, and then turn it over to Mardia Shands. So our first presenter is Mardia Shands. She's the Regional Chief DEI Officer at Swedish Health Services. Nwando Anyaoku, MD, is the Vice President at Swedish Chief Health Equity Officer for Swedish Health Services. We also have Peter Mann-King, a Manager, LGBTQI and Program at Swedish Health Services, and Mattie Mooney, who's a Senior Program Coordinator for Transgender Health at Swedish Medical Center. All four I've heard them speak before. They just do a great job. So I really want to turn it over to Mardia to kind of get the ball rolling, and I'll turn my camera off. But thank you guys for doing this. We just think this is just an excellent way to finish our 25-year celebration. And then we'll probably extend this to about 4:15, because I know we're starting a little late. So thank you guys, and I'll turn it over to Mardia and Dr. Anyaoku. Thank you.
Good afternoon, everyone. It is truly our privilege and our pleasure to be here today to introduce the work that we are doing at Swedish Health Services with regard to health equity and diversity and inclusion. My name is Mardia Shands, and I have the privilege of serving as the Chief Diversity, Equity, and Inclusion Officer for Swedish Health Services. I would like to introduce my partner, my dyad partner, Dr. Anyaoku.
Hello, everyone. Thank you for having us today. My name is Dr. Nwando Anyaoku. I serve as Chief Health Equity Officer for Swedish Health Services. I'm a pediatrician by training, and it's really a privilege to have this conversation with you today.
Next slide, please. So just a little about who we are and what is our mission for this work that we do. As you can see, and I won't read it to you, Swedish as an organization recently within the last year in 2021 has formed the Office of Health Equity, Diversity, and Inclusion. And Dr. Anyaoku and I work as dyad partners to really promote health equity and diversity and inclusion within the Swedish organization. And as you can see here, we serve and strive to improve the health and well-being of each person that that comes through our doors, and we try to do it in a culturally competent manner. And we work on ensuring that we have a diverse workforce and that we have an inclusive culture in our organization, because ultimately we want to have health for a better world. Next slide, please.
The next two slides just have our faces on it, but really they're prompt to talk about how we're thinking about what this work looks like. And really in the context of a pain conference, a 25-year celebration of the work to manage pain in patients and help people live a fuller life. How do we connect the work that we're doing and what we're bringing, what we're looking to bring to Swedish to this work? Yeah, and you're going to hear a pretty impressive presentation in just a little bit, but we really think about the work that we do in the Office of Health Equity, Diversity, and Inclusion as two sides of a coin. And so I focus on health equity, which is more clinical focused, more looking at how we are delivering culturally competent care, how diverse our providers are, how we understand the impact of having diversity in our provider pool, and how people, and all of us in medicine went into to care for people, and understanding how that is coming across, how that is landing for the patient population that we serve, and where bias, implicit and otherwise, may play a role. The next slide. And Mardia?
Next slide, please.
Yeah, you're up.
Okay. So again, when you take a look at our work, we have it divided and delineated, I should say, on health equity and diversity and inclusion. And I'll speak particularly to D&I, and Dr. Anyaoku can speak to health equity. And just really quickly, I am my work is really focused internally on ensuring that we have a workforce that is diverse, a workforce that in a work environment that is inclusive. So I really focus on how do we bring in diversity of thought, diversity of lived experience among our caregivers and our clinicians and providers. And as we know, the more diverse that your workforce is, and the workforce as it reflects your patient population, that drives cultural competence. And cultural competent care allows us to provide care that really speaks to what the patient needs are, what are the patient lived experiences. When we put a model of care in place, it takes into consideration what are the realities of a patient's diet, what are the realities of a patient's lived experiences. And so we want to make sure that we bring in diverse care providers and diverse clinicians and physicians into our workplace so that we're providing culturally competent care. And so we're really focused on diversity recruitment and ensuring that we provide training and education for our providers that enables them to be able to meet patients where they are. And also, when we bring in diversity into our organization, how do we create a culture that's inclusive so that people stay in the organization and are retained in the organization and feel as though they can bring their whole selves to work? And so my role is to bring that diversity into the organization, educate people about that diversity, and then, of course, create a culture where people feel as though they belong and that they can lend their level of expertise and diversity of thought into the way that they practice medicine. Dr. Anyaoku?
Indeed, and when we've got that diverse workforce in an inclusive culture, we have providers and caregivers who are culturally competent in the way they deliver care. It allows us to look at where there have been historical biases in care delivery to patients, which have resulted in inequities. And, we talk about health disparities, and I like to call out the difference between disparities and inequities. And that disparities can occur for biological reasons, but inequities tend to be based on injustice. They tend to be based on historical constructs that have affected the way that we deliver care, on the way that some populations are able to receive that care. And sometimes, and often the way to bridge that gap is first to identify it, but then, have your culturally competent care team aware of different modalities that you can, bring into place to bridge the gaps in the outcomes for different populations. But there's a bullet there that talks about community health, because community is where you can come with partners who can help you bridge the gap between the intention of the caregiver and the healthcare provider and the ability of the patient to receive the care in the way that it's intended. And so the next slide will probably skip past because I am really excited for you to hear how all of this comes together in the space of managing pain for diverse populations. We're proud to have, as part of our Office of Health Equity, Diversity and Inclusion, the LGBTQI plus program and the Transgender Navigator program. And Mattie Mooney is a senior program coordinator for transgender health. And they have prepared this presentation for you to think about how this work, how these biases show up in our everyday work. So I would like to turn this over to Mattie, and thank you for having us, and you're in for a treat.
Thank you.
Thank you. This is examining our own implicit biases in pain management. Next slide. I just want to disclose that I do not have any financial interests or relationships to disclose. Next slide, please. It looks like there's kind of a block in the middle.
Yeah, Mattie.
Of,
Yeah, Mattie, this is Stephen. We're trying to figure it out. They're trying to remove it on Danielle's side.
Oh, okay.
Yeah, so we're aware of it. So sorry about this. Sorry.
No
Peter, are you
problem.
seeing anything on your screen?
No problem. I
not.
will just.
I'm just seeing the slides on my side.
Okay, no problem. We'll keep troubleshooting, keep going. Thank you.
Yeah, no problem. I'll just go through. So some of our training goals today are defining implicit bias and understanding how implicit biases work in conjunction with other levels of marginalization to create barriers to accessing healthcare. Another one of our training goals is identifying your own implicit bias and understanding / reflecting on how they may affect care provision. And we're gonna develop some strategies for self-awareness and self-accountability, and also unpacking implicit bias. Another one of our training goals is understanding why utilizing concepts of anti-oppression are central to providing culturally competent pain management. Next slide. And here are some community agreements and reminders. And I think that with the current platform, we may not need these depending on how the question section goes, but I'll go through these anyway. One of them is speak from your own experience, listen to understand and not to respond, no shaming, blaming, or scolding, that's including yourself, seeking intentional learning and not perfection. None of us is perfect, but we're all on a growth trajectory. So try on also, being open to trying something new instead of immediately rejecting. And then also naming the elephants in the room, maintaining confidentiality, of course, and then committing to non-disclosure. Next slide, please. So one of the things that we are going to start with is the fact that messages absolutely matter, right? We are born receiving various messages about who we are, how we fit into our world, our society, cultures, families. And conversely, we also receive various messages about who other people are in relation to our perceived place or status. These messages can manifest in the form of stereotypes, right? And we know that stereotypes are a widely accepted and oversimplified judgment or assumption about a person, place, thing, and the traits or behaviors that they possess. These messages can be explicit messages, implicit or implied. For example, we absorb messages about our weight or our socioeconomic class, our race, our skin color specifically, our religions or our lack of religion, where we are from, cultural norms, societal norms, etc. These are the building blocks to our sense of identity. So who the building blocks for who we are, but also the building blocks for the potential of stereotyping and othering folks who fall outside some of those personal, societal, and cultural norms. Next slide, please. Okay, so we oftentimes hear about stereotyping being horrible, right? Being bad, and we don't want to do it, right? But we also need to understand that stereotypes are absolutely normal, right? Stereotypes are evolution's way of keeping us safe and alive. And I put some pictures here, you know, as a pop quiz of a few snakes. Are you able to tell which one is poisonous? Maybe, maybe not. Some of us have heard the, give me just a moment. Of course, as human beings, stereotyping has always been a way for us to conceptualize the world around us. Again, evolution's way of keeping us happy, healthy, safe, and alive. How many of us have heard the saying, if red touches yellow, you're a dead fellow, or if red touches black, you're okay, Jack, right? Someone clever, sometime decided that he was sick and tired of everyone being bitten by snakes. And so we know, however, that even with snakes, the things that we tell ourselves to avoid danger or the unknown are not always true. And we've come to rely on this rhyme and other types of things to stay out of danger. Similarly to stereotypes or anecdotes, we also tell ourselves things about the character or the safety or the trustworthiness, et cetera, of people that we cannot always rely on them to tell us the truth about a situation or a person. And validly, people in many parts of the world still use social and ethnic categorizations to keep themselves safe within the context of their cultures and communities as a means of absolute survival. In terms of snakes, it's best to just leave the colorful ones alone. And in the American cultural context regarding people and care provision, it's important to go into interactions and situations aware of the biases that you may carry in so that you can leave them at the door and not allow them to impact how you are treating others as a result, right? Next slide, please. So this next slide is one of my favorite clips to use. It's a pretty engaging tool that explains oppression and its impact. In order to really understand the ways that stereotypes and bias, both implicit and explicit, make their way into our psyche and subsequently our behavior, we must first understand oppression and our relation to it against the backdrop of our own identities and social statuses. So we will start Legos and the 4 Eyes of Oppression.
It's a word that's often used as a blanket term, but there's actually a whole lot more to it. There are 4 interlocking aspects of oppression: ideological, institutional, interpersonal, and internalized. And it might seem like a small difference, but it's very important to be able to distinguish between each kind, because understanding oppression is the first step to fighting it. Let's start with the core at the heart of every form of oppression: ideology. Every system of oppression comes from the idea that one group is somehow better than another. Ideological oppression starts when the dominant group associates positive qualities with itself and negative qualities with the marginalized or othered group. Ideological oppression describes the deeply ingrained social root of inequality. It's the larger overarching idea that leads to the isms. For example, the idea that black people are dangerous is ideological racism. The idea that poor people are lazy is ideological classism. Ideological oppression leads to institutional oppression. Institutional oppression is the way that systems and institutions manifest the dominant ideology. Institutions control access, who is able to get to what and how. This includes legal rights, police practice, access to medical care and education, public policy, political power, and media representation. For example, when women make 2/3 of what men make, that's institutional sexism. When a building is constructed without wheelchair ramps, that's institutional ableism. All of this leads to interpersonal oppression. Interpersonal oppression is probably the easiest to recognize because it happens all around us. Interpersonal oppression is the way that people play out discrimination and violence on each other. It can take the form of microaggressions, jokes, stereotypes, and harassment. For example, when a student is bullied for being gay, it's interpersonal homophobia. When a Muslim person is told that they're a terrorist, it's interpersonal Islamophobia. And all those forces, ideological, institutional, and interpersonal, lead to internalized oppression. Internalized oppression is the way that people with marginalized identities internalize narratives of their own inferiority. It's what leads people to feel less than. This is the end goal of oppression. The oppressive party doesn't need to exert force any longer because the marginalized group is enacting oppression on itself to maintain the status quo. It's important to remember that it's never a marginalized person's fault that they feel internalized oppression. It's simply what happens when someone faces negative stereotypes, low expectations, and ongoing discrimination. So, for example, an immigrant feeling embarrassed about having an accent is internalized xenophobia. When a trans woman feels that they can never be a real woman, that's internalized transphobia. So, to review, the 4 I's of oppression are ideological, institutional, interpersonal, and internalized. Each of these types are interconnected and completely supported by the others. They can never exist on their own and can even be seen as a cycle. Now that you understand the different kinds of oppression, you're even more equipped to fight it. Don't forget that any effort to dismantle oppression should aim to address it at all 4 of these levels. Thanks for watching.
Oh, perfect. Thank you. Next slide. So implicit bias is a personal preference or predilection that we oftentimes are unaware of, most times are unaware of, and which quickly happens outside of our control. It is a bias that happens automatically and is triggered by our brain making quick judgments and assessments of people and situation, and is often influenced by our background, our cultural environment, and personal experiences. Just a quick think to yourself question. Are folks able to think of any healthcare disparities / inequities that occur in part due to implicit bias? And a second question to think about is, why do you think that these disparities / inequities continue to persist? Some of the inequities that I have, that I've been able to see is the ever-growing Black maternal mortality rate, the fact that women are less likely than men to receive more advanced diagnostic and therapeutic interventions, that physicians are more likely to interpret men's symptoms as organic and women's as psychosocial, that patients who are obese are more likely to be told to make lifestyle changes for their symptoms, while patients who weigh less are prescribed medication. Also, that there was a study done in 2016, published in the Proceedings of National Academies of Science, where there were trainees who believed that Black people are not as sensitive to pain as white people, and as a result, were less likely to treat Black people's pain appropriately. Conversely, in that same study, 40% of first and second year medical students endorsed the belief that Black people's skin was thicker than white people's skin. A meta-analysis of 20 years of studies covering many sources of pain in numerous settings found that Black patients were 22% less likely than white patients to receive any pain medication. Next slide, please. So in this next slide, give me just a moment to arrange. In this next slide, we talk about pain with a focus on biases in ethnic minorities. It shows us how implicit bias impact how pain is managed based on racial and ethnic identity.
We should be feeling. There are several tools that can be used to measure pain. The gold standard for assessing pain is considered to be the numerical rating scale, which ranges from 0 to 10, 0 being no pain and 10 being maximum pain. This scale is based on self-reporting, which means each patient will evaluate what level of intensity they believe their pain to be at. For patients who are unable to report their own pain intensity, the Behavioral Pain Scale and Critical Care Pain Observation Tool are other good options. Despite these tools, there is no validated, quantifiable biological marker of pain. This means we cannot measure pain the way we might be able to measure heart rate or blood sugar level. When diagnosing and treating pain, the doctor and patient must rely on interpretation and trust. Unfortunately, this can occasionally lead to biases in pain care. Bias can occur when not all patients are treated the same due to physician judgments or beliefs. Subjective measures, such as a pain measurement, are more susceptible to bias. There is lots of evidence which suggests that there are large, widespread inadequacies in pain treatment, which tie into cultural, societal, religious, educational, political, and logistical attitudes. An estimated 80% of patients in both primary and tertiary care settings are not given adequate treatment for pain. These inadequacies have led to significant physiological, psychological, economic, and social impacts on patients and their families. Issues with diagnosing and treating pain are magnified in ethnic minorities. Community-based studies have demonstrated that ethnic minorities are more likely to experience serious or activity-limiting pain. Despite this, they often suffer from inadequate care for acute and chronic pain when compared to non-Hispanic whites. This occurs across age, gender, and pain intensity. Disparities in pain perception, assessment, and treatment across races have been identified throughout the healthcare system, from emergency rooms to post-operative settings. These disparities occur in all types of pain management, whether it be acute, cancer-related, chronic, or experimental. Inadequacies in pain care may be due to the fact that physicians routinely underestimate a patient's reported pain intensity for acute and chronic pain conditions. When assessing patients of an ethnic minority, the degree to which they underestimate pain is even greater. One study found that physicians rate pain in African Americans greater than 2 points below the self-reported 47% of the time, compared to 33.5% for non-African Americans. As well, the study found that physicians were twice as likely to overestimate pain in non-African Americans. Research suggests that the reasons behind these inequalities are complex. One major contributor is physician attitudes and stereotypes. Much of the time, a physician may not mean to impart racial bias. However, implicit stereotypes about different races can often result in unconscious discrimination. A limited awareness of a physician's own cultural beliefs and stereotypes surrounding pain, minority individuals, and narcotics may contribute in large part to this unconscious discrimination. Factors such as the tendency for minorities to underreport pain and a lack of knowledge of pain on the part of physicians also play a part. We should note here that biology has not been considered a key factor. There is no compelling data at the moment which suggests that biological racial differences in pain perception exist. So, how do we combat bias in pain management? First, it is important to ensure that all healthcare providers are adhering to best practice guidelines for pain management. Second, better formal and informal education on pain management should be given to doctors who are not pain specialists. Third, finding valid biological indicators of pain will allow the field to become more objective and less at risk of bias. Currently, there is some research that has associated pain with specific molecules in the body. When it comes to racial bias, physicians should work to become aware of their own implicit attitudes that may be affecting the way they treat patients of ethnic minorities. This way, they can regulate and overcome the biases they may have. Furthermore, allowing for a space in which ethnic minorities feel empowered to communicate openly and honestly with their healthcare professionals is extremely, extremely important. Thanks for listening to our video. Check out our YouTube channel to find more.
So before we move on, that slide is a video in a series called Demystifying Medicine. It was created at McMaster University, which is a public research university in Ontario, Canada. And it looks like we're going to restart the slides just to make sure that everyone can see I'm moving forward. Give us just a moment. Okay, so while none of the conditions listed here are new to you all, I wanted to go over some of the symptoms of unmanaged pain, specifically uncontrolled persistent pain. And while we go over these, think about the increased institutional impact of unmanaged or undermanaged pain and how that impacts marginalized groups and how it can perpetuate a cycle of implicit bias on healthcare teams. Some of the deconditioning complications of uncontrolled persistent pain or unmanaged pain, undermanaged pain are, immobility and obesity. Excess weight may further overload a painful deconditioned anatomical site. There's some hormonal complications. So based on emerging research data, it appears that uncontrolled persistent pain may affect just about every endocrine system in the body. And then also neuropsychiatric complications. The problems of insomnia, depression, suicide, attention deficit, memory loss, and cognitive deficiencies are also extremely common in persistent pain patients. I want to be vulnerable with you all for a second and share a personal story about my own experience with implicit bias for my own pain management. I am a trans person, and I made the decision to obtain a bilateral mastectomy 2 years ago, otherwise known as a top surgery. I was extremely excited about the procedure, and while I didn't exactly know what to expect in terms of pain, I was hoping that it would be manageable. It wasn't. I probably really could have used one of Dr. Spiegel's VR headsets, but I didn't have that. I am a person with a pretty low threshold for pain, but I hide it well, and I'd like to think that that comes from my years of hair relaxers and hot combs. Thanks, Mom. The pain medications that I received were not even touching the pain that I felt. And I made an appointment with my PCP, who also happened to be on vacation, so I got someone who was covering for her. And while at this appointment, 2 days after surgery, with drains still in, I shared how I was feeling. And what was weird about the interaction was that rather than empathy, I was met with a skeptical look that was kind of similar to this, and told to remove the dressings that I had on my chest, and told to remove them on my own. And so you can imagine just kind of how fumbling I was with these like huge dressings, and I had like a pad to keep all of the stuff in, and it was just really ridiculous. But she wanted me to remove the dressings so that she could see. Specifically, she said, "Can I see?" I showed the doctor, and honestly, tried. I was in pain and really too tired to advocate for myself, for fear that one, I wouldn't get help out of spite. So I said nothing. She then kind of poked and prodded around my chest as if she was like making last corrections on a science project. And I said, and then she said, I can give you lidocaine patches and gabapentin, and we can see if those work. But the thing was, I had brought in gabapentin already as one of the pain medications that I had already been given as a part of my pain management. And I looked at her for a minute, really defeated, and I took the lidocaine patches that clearly did nothing. And I suffered through the pain. And when I tell you that the pain that I felt was worse than anything that I've ever experienced in my life, I often refer to it as torture. And to this day, I still endure panic attacks at pain more severe than a headache as a result. One of the lowest points that I felt in that situation was wanting to die, which was not fun, but also something that I'm also really not proud of, but also something to think of in terms of how pain can send people into modes of desperation, but also how potentially addictions start, right? When folks have unmanaged or undermanaged pain. I was considering sending my friends and partner out to find illegal drugs to help with my pain levels. Thankfully, I endured, with the help of my dad and my friends and family, but not without some pretty lasting psychological impact and trauma as a result. Next slide, please. So to bring the point on home regarding some of the unintended consequences of bias in pain management, we will play an interview with Soledad O'Brien regarding the opioid crisis. And that will start soon.
How do you talk about white supremacy with your family and your children?
You know, it's interesting. My boys are 12 years old, and I think that they're very binary, right? There's like good people and there's bad people. They haven't, you know, they're not sort of, and the girls who are a little bit older, 16 and 15, I think that they begin to understand that there's a lot of nuance in kind of what people do. So with the boys, it's a very, you know, they're very clear. There's a group of good people and there's a group of bad people. We were having a conversation today. We were driving in the car and we were talking about heroin addicts. And my son actually was asking, was there ever a time when racism was a positive? I said, well, that's a very interesting question.
It sure is.
Let me tell you about the number of Black people who are heroin addicts and how doctors not prescribing pain pills to African Americans because they believe they're going to sell them, or they believe that Black people don't feel pain at the same levels that white people do, or just in general, they don't actually want to help their Black patients with pain. All these things, there's a fair number of studies on all of them. So, for example, an African American who goes and gets wisdom teeth pulled will not get the 90-day supply of Vicodin that a white person who has a really good Blue Cross Blue Shield coverage, they'll get, as my girlfriend did, 6 pills and, you know, told, listen, if it's really bad in 2 days, come back and we'll re-prescribe. They have saved Black people from the epidemic that is the heroin epidemic, right? Because they're not getting access to pain pills. We know that the number of pain pills you have helps correlate to whether or not you become addicted to opioids. That becomes correlated to whether or not you're going to get on heroin. People who can no longer get pain pills often turn to heroin. It's a much cheaper version, clearly, right? So we have all these deep, intense conversations about like, so racism kind of helped out, right? And this is the only one case, by the way, that I have found. This is kind of it, from what I can tell, the one, but a biggie. So I think that they are very binary, like racism's bad, except in this one thing where maybe it kind of had these unintentional consequences. I think that they just think of white supremacists as bad. They don't really understand it. I think they think of it as the same as a person who robs someone, a kid who pushes someone on the playground, that's just a bad person. They don't really understand, which is kind of sweet, right? Because they're young, like all the effort and intention that goes into I think the psychology of trying to make people believe that other people are lesser. Like, I just don't even think they can wrap their heads around that part of it. They just think there are some people are bad and there are other people are good, and that's kind of the way the world works.
Thank you. Next slide, please. So to wrap things up, since we're kind of pressed for time, here are some, a helpful anagram that we can use to remember how to stay aware of what we bring into interpersonal situations with both, folks out in the community, but also our patients. Number one, I, in the I in implicit stands for introspection, right? So we can explore and identify our own prejudices by taking implicit association tests or through other means of self-analysis. However, I want to add a caveat that the implicit association tests are not always completely foolproof or not always completely accurate. The M implicit is for mindfulness. Since you're already more likely to give into your biases when you're under pressure, practice ways to reduce stress and increase mindfulness, such as focused breathing. The P in implicit is for perspective taking. Consider experiences from the point of view of the person being stereotyped. You can do this by reading or watching content that discusses those experiences or directly interacting with people from those groups. There have been tons of studies done regarding the racial makeup of people's contacts or associates or friends, right? And so one of the ways to support with eliminating some of those biases or being aware of some of those biases, right, is to branch out, right? To get to know different people and to have those different people play a role in your life, right? The L in implicit, right, is to slow down. Before interacting with people from certain groups, pause and reflect to reduce reflexive actions. Consider positive examples of people from that stereotype group, such as public figures or personal friends. And again, this goes back to the one above it, where if you don't have friends who encompass or embody the identities of the people that you're serving, maybe it's time to start. The I is for individuation, right? We want to evaluate people based on their personal characteristics in terms of serving folks when, in a healthcare setting, rather than those affiliated with their group, right? This could also include connecting over shared interests, right? And when we're talking about care provision, we're evaluating people solely based on the information that we have, and we're not pulling any sort of extraneous information that might not be stated, or that there's a history for in their chart. Next slide, please. C is for check your messaging. As opposed to saying things like "we don't see color," use statements that welcome and embrace multiculturalism or other differences, right? And we know that "we don't see color" is indicative of erasing, right, the very real realities of the fact that we do see color, right? And there are differences in how folks are treated as a result of that, right? And rather than erase those experiences, right, and act like they don't exist, we want to know that they exist and be aware of them, and do more to address and change them. And then I is for institutionalized equity, which is something that we're doing right now, right? The Office of OHEDI is doing that now. And that is supporting a culture of diversity and inclusion at the organizational level. And this could include using an equity lens tool to identify your group's blind spots, or reviewing the images in your office to see if they further undercut stereotypes. And something that I'll say about that is I want to mention that I love that we're discussing this, and we know, however, that trainings alone do not solve the issue, right? You're not going to walk away from this training and be like, boom, no more implicit bias. Like, I can do this. There's going to be no mistakes. That's just not realistic, right? Things like consistent trainings, education, institutional reinforcement, and both institutional and personal accountability are huge factors in creating the kind of lasting change and some of the implicit biases that contribute to the inequities and disparities that we discussed today. And then the last but not least is take two, right? Resisting implicit bias is like lifelong work. You have to constantly restart the process and look for new ways to improve and monitor your behavior. And one of the things that I do to constantly be aware of just kind of my own thought processes, right? Because we all hold biases, right? Is, just to take a step back, right? But also to constantly be learning, constantly be reading, constantly making sure that, I am aware of what folks are saying about their experiences, what folks are saying about, the lives that they live, et cetera, and how different barriers impact them. And so that wraps up our presentation here. And I hope that you all are inspired to continue learning about the ways to be intentional about the care that you give to your patients. Thank you. Oh, and the next slide, by the way, is just some resources for continued exploration and learning that I found to be really helpful. I really, really, really recommend the book at the end. It's called The Pain Gap: How Sexism and Racism in Healthcare Kills Women. It's an amazing book that I really recommend to everybody. Thank you.
Yeah, thank you, Mattie. And I'm just going to quickly share a little bit about the LGBTQI plus program, and then happy to have some questions as well. So my name is Peter Mann-King. I work with Dr. Anyaoku, Mardia, Shands, and Mattie Mooney in the Office of Health Equity, Diversity, and Inclusion. I am the program manager for the LGBTQI plus program, and my pronouns are he, him, his. But I just also want to call out Mattie and their wonderful presentation today, and also sharing lived and personal experiences with us. So thank you to Mattie. So our program, we wanted to quickly just show an example of some of the work as it has happened here at Swedish, as an example of the journey and some of the places we can continue the work that Mattie highlighted, and Mardia and Dr. Anyaoku. And so this map is really just to show the evolution of a particular program like the LGBTQI+, that it doesn't just happen, similar to what Mattie said, I think, in one training or a few trainings, but that it happens at an institutional level, but by many folks, sometimes over years. And so really this program that Mattie and I are part of has been an evolution since 2015, and even before that, when we were able to really recount all the people before us. So it started with our medical director, Dr. Kevin Wang, really starting to think about how do we create some more education around LGBTQI+ health at one of our family medicine residents at Swedish. Grew into having LGBTQI+ symposium, which we now host similar to this symposium annually about LGBTQI+ health issues. And then starting to form more of community groups like our caregiver resource group across Swedish, and also thinking about how do we document and visualize our patient populations with sexual orientation, gender identity data. And then, thanks to the leadership of Dr. Kevin Wang here at Swedish, it really was a request of what's next? What do we do? And how are we serving the LGBTQI+ community? So that was an ask to Swedish leadership in 2019, and it really took about a year of figuring out what that meant before the work started. And so you can see here, Dr. Wang and then I, the program manager, started the current state assessment and the work to really say, what do we need as a program in 2020? And we were so fortunate along the way to start to think about the work that adding the work that Mattie does with transgender healthcare navigation, and most recently work around LGBTQI+ education that our program coordinator Vinnie Fox does as well. And so the work continues. The work that Dr. Anyaoku and Mardia Shands outlined is really where we're headed with a fully integrated Office of Health Equity, Diversity, and Inclusion, because LGBTQI+ issues really are intersectional in a lot of ways and must be connected to the broader work. And we are very excited to continue that journey in the greater office of OHEDI. And so quickly, we have 4 focus areas, and our overall aim is to be a leader in providing LGBTQI+ care for our Puget Sound community here in Washington State. And we are defining leader not as necessarily, leading in market share or leading in patient volume or utilization, but more rather as a place, an organization that brings together groups and learns together as leaders. So the 4 focus areas are clinical support for providers, recognizing that we need to support our providers in this space and learning more, and how do we set those foundations up as an organization, and hopefully be able to share the work across the region and state as well. Data improvement, how do we look more and better understand the LGBTQI+ population we serve, and track that information so we can be informed across the whole organization with the metrics that we currently track, like cancer screening rates, blood pressure control, and so many other metrics that we need to start to stratify, both by sexual orientation and gender identity, but also by race and ethnicity and all of the other spaces that we need to look deeper at. And then culture change. This is really going beyond our initial kind of how do you document sexual orientation and gender identity, but diving deeper into the topics around social determinants of health and LGBTQI plus community, race, ethnicity, and all the other identities as it intersects with the LGBTQI plus community to really advance our understanding and support our organization as we learn together in this space. And lastly, care coordination. This is a lot of the work that we hope to do with others, other health systems, other programs like ourselves, to continue to create some formal structures around how we refer our patients, what care looks like across the region, be able to share resources as well, because we know we can't do this work alone at Swedish and have to work and must work with other organizations and community orgs as well. And so that's divided into a logic model that we call a driver diagram here, and just wanted to visualize that quickly in a different kind of model and method, but this is how we're tracking some of the work that we think will impact the program and the work here at Swedish as well. And the program team. So you heard from Mattie Mooney, our Senior Program Coordinator for Transgender Health, who leads our healthcare navigation. Vinnie Fox is our Program Coordinator for LGBTQI plus education, and doing a lot of our curriculum development and education across our organization. Dr. Kevin Wing is our Medical Director, who leads our clinical space. And then I'm the Program Manager who supports the program and team moving forward. So that's a quick overview of everything we do in that program, and we're looking forward to continuing that work and happy to answer any questions that folks have.
Thank you. And I was actually going to turn this over to Mardia. Do you want to kind of take the questions?
Absolutely. So please, by all means, chat your questions, and we would love to answer them. So I'm looking at one of the questions here. The study that discussed showed that the providers put another pain score that is lower than what the patient actually reported. Was that a recent study? Mattie, I'm going to ask you to please come on screen and talk a little bit about that with regard to your source.
Sorry, give me just a moment.
You're on mute.
There you are.
Do you know which slide that was in? Because I guess I'm not knowing which study is being referred to, or which.
I think it was the study regarding the physician versus patient discrepancy in pain reports.
Give me just a moment to look through the slides. Are you able to refer to the particular slide?
Okay, perhaps it was a video. Perhaps it was a video.
It was the video?
Perhaps it was a video.
Oh. Well, if it was the video, I know that a lot of the, I could put a lot of the research from the video in, maybe in an email, or send it to you. Is that okay?
So here's what we'll do. We will put the source of the information.
Absolutely.
And make that available to this audience so that you can see how we cited and where we cited the information that was presented to you.
Absolutely. And also some of the things that I personally stated, not the stuff in the videos, is in the references in the back. So the things that folks can, the resources for continued exploration and learning. So you'll find a lot of the same things that I stated in how to identify, understand, and unlearn implicit bias in patient care, how we fail Black patients in pain, racial bias in pain assessment and treatment recommendation, and false beliefs about biological differences between Blacks and whites. And also some of that information is also contained in the Pain Gap, the book that I referenced as well. And some of the others are located, for example, this one in the actual slide itself. But if you are looking for the sources from the videos, I can also post those as well.
And to respond to the last, the clarification of the question, you wanted to know if it was recent. Most of those studies are within the past 2, 3, 4 years, then they're pretty recent actually. Yeah.
Yeah, it is mind-boggling. What I will share with you too, here's a source if you're curious too, to get additional information about this. The Institute for Healthcare Improvement is also a great source to find information, research information about these disparities that we speak of and have presented to you today. So you can look at the IHI website and you will see actual data that shows you the disparities between how pain is managed between BIPOCs, Black African Americans, people, Indigenous people, and majority populations.
The JAMA report, Journal of American Medical Association report, that validated that medical students still believe that Black patients experience pain at a lower level, I think was released just before the pandemic. I mean, this is real current disparities. And so we continue to see that. And, you know, one of the things is that, you know, as everybody on this call knows, pain is a vital sign, right? And so, well, let me not say that because that's had some implications, but pain gives you a message, right? It tells you, it gives you a signal as to what's going on with the patient. And if you don't believe the patient's pain, then they don't get the care that they need. And then, it, you know, it sort of continues to go down paths that lead to bad outcomes. And generally we, you know, not generally, we all think of ourselves as clinicians as practicing, you know, evidence-based medicine. And you are, except for the fact that if your assessment has put the patient in a different category than where they truly are, then you're practicing evidence-based medicine that's not applicable to this particular patient. What are some of the steps we can take as care teams to start working together to increase our own awareness? I love that.
So again, this is where implicit unconscious bias comes into play. And what we do is try to educate our care teams to disrupt their implicit unconscious bias. And there are several ways of doing that. One of the biggest things that we try to do to educate people is to pause. And pause really allows us to slow down and to really start to think about the action that we're taking and to really start to think about individualizing people as opposed to putting them in categories. And when you start to individualize a person and stop putting people in categories, then you really start to think about the decisions that you're making and you start to challenge your beliefs and your mindset and start to think about, okay, this belief that I have about this individual, is it truly based on facts and data as opposed to my mindset and my beliefs and what I believe about people in this category as opposed to this individual. And it is a practice skill. And if everyone on the team holds each other accountable to pausing and stopping to think of people as individuals as opposed to a group and a category of people, that is one of the biggest ways that you can start to disrupt implicit unconscious bias, because it allows you to give yourself time to really deconstruct what your beliefs are about that category of people, as opposed to the individual that is standing before you that is seeking care. So my advice to everyone on this call as people is just to pause for a minute and start to think about, am I operating off of a belief and a mindset, or am I operating off of evidence and data that says this individual requires this, as opposed to what I may have perceived based on what mass media is telling me, what my lived experience is telling me, what my grandmother told me about these people, and really start to think about this individual needs are this. And so pause is truly the biggest disruptor of implicit unconscious bias.
And I would say, just to go back to the earlier question, where does the research lie? Is it recent? Is it true? That's always a challenge, right? Because none of us truly believes that this is happening, right? Like, we're telling this story and you're thinking, I know this is not happening here. It's not happening in my unit. And so what I ask people to do is to look at your outcomes, right? Look at the metrics that you measure for the care you deliver, the outcomes for your patients, or sometimes even the process. And if you're looking at minority populations, and if you look at your data as a whole, it's often going to tell you you're doing pretty well, right? But when you disaggregate that data and start to look at how those outcomes are showing up in subpopulations. So, if I look at all the patients that come through Swedish as a whole, we're doing great. We have these great outcomes, but then I start to filter it by race, ethnicity, and language. I filter it by sexual orientation and gender identity. And all of a sudden, what rises to the top is that in these populations, whether they're Black, Latinx, or LGBTQI populations, we are not doing as well with the metrics that we've already ascribed value to. So we're not asking you to come up with new measures. Just look at the ones that we already look at, because we've already established that it's valuable to measure the way we deliver care in these ways, and then filter it and see what rises to the top. It will boggle your mind every time, because it is real everywhere, unfortunately. And that's the work that we have to do. First, to acknowledge it, see it, and then to start to identify what are the drivers. Where can we pause and ask the question, how is bias playing a role in this outcome? How is bias playing a role in this disparity? And what can we do to change, these outcomes? That's the journey that we're hoping to bring everyone along with us on. Okay. What training?
We are launching in 2022 a series of implicit unconscious bias training for not only our core leaders, but also our clinicians and our caregivers, our providers, training around what exactly is bias, what is implicit unconscious bias, how to recognize it. Let's start there. We're going to recognize it, define it so that people can see it. And then what are the tools of disruption? And Mattie put some of that in the chat for folks to be able to see and start to assimilate that information. And so that training is coming out in 2022. We've already started to model it and with some of our teams. And so we're going to be rolling that out. That is actually one of the DEI goals that we've set for the system, that we're going to make that a compulsory training for the organization, that people understand and recognize what exactly is implicit unconscious bias, how does it show up, and how does it play out, what are the implications, and then most importantly, how do you disrupt it?
And and for those who are not working at Swedish or Providence or a large system, one of the, I hesitate to call it a silver lining, but one of the things, the fallouts from this last couple of years where the pandemic has shown a spotlight on historically established inequities, and has also shown a spotlight on the societal inequities across the board. is that there has been an awakening of lots of organizations and people to say that this is work that's important to do. And as a consequence, beyond a system like Swedish, where we have the opportunity to build OHEDI and do this work for our teams, across society, there are other organizations that are actually beginning to put work into place in this space. And so, like the professional societies, the American Academy of Pediatrics, American College of Physicians, the I don't know what association the pain people are in, but those big organizations are actually beginning to do work around there. Washington State Medical Association has formed a DEI committee that's actually going to begin to do some of this work early in 2022. And so across society, large organizations and professional societies, King County Medical Society, Washington State Medical Association, all of those are putting together products that will allow people to have access to some of this training who are not part of a large health system. Now, if you have privileges at Swedish, you're part of our system, and therefore you can have access to that as well. If you don't, though, there are other resources out in the communities. A lot of them are in development, but I can assure you that over the next 6 months or so, there will be options that you can take advantage of. I hope that's helpful.
Mardia, any other questions in the chat? We have time for one more, I think, and then we'll wrap up. This has been excellent.
No new questions that we can see in the chat.
Okay. Well, I want to thank you guys. This has been an excellent presentation in a really good way. I think you said, Dr. Anyaoku, that the silver lining, everything that's happened in the last couple of years, that there's goodness that can come out of this and how we can do a better job. So we really appreciate you guys doing this. We wanted to apologize if there was a glitch. The system crashed, but it's back up, and we were able to get 50 people back into the meeting. So we really appreciate everyone doing that. So this will conclude the final session. So thank you, Mardia, Dr. Anyaoku, Mattie, and Peter. Gordon and I want to just quickly thank all of the attendees, all the speakers. It seems like it was a couple of days ago that we started this meeting, but it was only this morning. And we also enjoyed the talks from Monday through Thursday, the lunchtime talks. Again, thank you everyone for attending. Thank you for our final four speakers. We really appreciate it. Gordon, thanks for 25 years of doing this. Again, we will conclude the meeting now. Again, we want to thank everyone, and we're looking forward to next year. That's right, for the 26th. I don't think that's called the Quadrant Centennial. It's got a different name. So, but we'll be ready.
Quadrant Centennial +1.
+1. That's it. Okay. Thanks, everybody. Again, have a good weekend and safe holidays too.